Welcome, ladies and gentlemen, to this webinar, and a special welcome to the people at home logging in. I hope I will be able to give you a positive learning experience today with this presentation. And as you know, we will focus on the restoration of large-sized cavities. The evidence shows us that the biggest challenge of today for dentists is to meet some criteria, and the criteria of restoring teeth that are severely damaged and to create a complex that is functioning very well in terms of biomechanics. And we will have to look at the biomechanical features of teeth and also the biomechanical features of the restorative materials. And I think that we will let pictures do the talking for a few moments here, because one of the biggest examples is a small cavity. A small cavity restored using some amalgam some years ago, and as you can see, the amalgam is perfectly within the criteria for the use of amalgam. It's a very shallow cavity, it's not very wide, and still we see that there are some biomechanical issues. In fact, the material and the tooth are not really behaving well together, creating some severe cracks on the distal, on the lingual. We see that this is a pretty big issue, honestly. The next slide shows you how deep and how wide the cracks have become. And it will, as you can see on these slides, lead to some biological issues and secondary effects. It will even may lead to complete failure of the restoration tooth complex with loss of vitality, as you see here, and maybe even loss of the tooth, because in this case the fracture is really going deep into the root canal system. So this patient is informed of the very low chance of survival. We need to be talking about implants to these patients, and it would be nice to reach a final decision before there is some bone loss eventually. Now, this is a pretty obvious example of very small cavity having severe consequences and eventually dramatic failure. The reason why this fails, or the reason why the total complex fails, it's dual, honestly. It's material choice, and probably it's the fact that material and tooth don't act well together as one team, let's say. So let's give another example where the failure is not as dramatic, but where you see that the restoration, for example, really lasts a long time. This restoration can last like 20 years. And we can be very proud of the restoration that is lasting for 20 years, but if the tooth fails after 20 years, the real value of the restoration is not as high as we would like it to be. I think the final objective should be preservation of the tooth and not necessarily preservation of the restoration in itself. Luckily, the failure here is not dramatic, and we can restore this. And as you will see during the presentation, we will be able to restore this in a very predictable way. Another small example is, I hate to say it, but it's my tooth, honestly. And as you can see, failure happens also with composite. It's not only, we don't want to blame amalgam, but we want to show that even composite restorations fail. And especially if we don't take into account some general rules to play, if we don't follow guidelines in relation to preparation, in relation to cavity design, in relation to cusp coverage guidelines, I think we might have severe dramatic failure again. So it brings us, of course, to the strategy of what we would like to do and share with you today. There's one thing, and that's crack propagation, stopping the crack propagation, and otherwise is prevent new crack development. It's a dual objective, and it would be great if we could meet those objectives with let's say some good material, and otherwise with some good approach, a healthy, sound approach in the mind on how to address those cavities that we need to restore. In relation to preparation design, I think we can be very clear, and it's pretty obvious that the sharper the angles are, the higher stress there will be created within that cavity, and the more rounded those internal angles are, the less stress we will create. Now, the difficulty of dentistry of today is that many times we have to redo restorations. We have like old amalgam restorations that need to be replaced, and we end up with existing cavity designs for amalgam, and we need to restore those cavities with another material. And then, of course, we already have some damage done. So it would be great if we could at least soften the damage by making good choices in relation to cavity design and in relation to material choice. So let's go a little deeper into that cavity design, because it will help us, honestly. And this is like known for ages already. And it's like basic criteria, and it still stands as criteria. When we look at the criteria for cavity width, I think we can be sure, and we know that we are on the safe side when the width of the cavity is not more than half of the intercuspal width. We are within safe limits. This means that the surrounding tooth structure here is thick enough, is strong enough to function with the restorative material inside. The criteria for this is pretty obvious. It's 2 to 2.5 millimeter of thickness, of wall thickness, that we need for that wall to have a very good intrinsic strength left. It's clear that if we don't respect this cavity preparation, and if the preparation ends up bigger than this, wider than this, if we end up with walls which are very thin, which are maybe undermined, only consisting of enamel, there will be some biomechanical issues and failure. The biggest problem what we face here is that, as I said before, I mentioned before, we end up many times with cavities like this to start with. It's not necessarily our choice to drill a cavity like this as a result from caries removal. So many times you have an old amalgam restoration leading to this type of cavity, and we are tempted anyhow to keep the surrounding tooth structure, because if we're going and if we want to do this in a direct way, if we want to restore these teeth in a direct way, we will tend to keep those cusp tips. We will want to keep some references for occlusal morphology. We want to be preserving as much tooth tissue as possible. And what we tend to do, of course, is to take some risks, because what will happen, since the wall thickness it's not enough, loading, dynamic forces will create some fatigue within the cusps, and it will create, as even with a bonded restoration, it will create a false sense of security that everything will be bonded together. But know that the thinner the walls become, the more fatigue there will be. There will be more flexure of the cusp walls. The fatigue will have its effect on the bonding, and eventually the wall will fracture. So this is something that really should make us think about, okay, there is some need for cuspal coverage. And I think that this image can be translated into clinical, and it's really helping us a lot to understand what is really happening. A very quick example of a cavity that is too wide. It should never have been restored like this in this cavity design, because what happens is, fracture along the complete wall because of a combination of two things. The sharp angles inside of the cavity, the very thin walls which are left, fatigue, and then we get fracture. So this could be prevented if we would respect some general guidelines about cusp coverage. So if we will be thinking now about, okay, what material could give us some options in having a better biomechanical approach on things, don't expect that one material can be the miracle and the solution to all the problems. There still will be some rules to follow in relation to cusp coverage. Another example is this one. And as you can see, probably there was some amalgam in this cavity before. The amalgam has been replaced with composite. People believe that they could bond everything together, but what really happens is that maybe even with the amalgam in place, we had some creation of cracks. Maybe depolymerization, shrinkage, and stress has led to fractures of this undermined wall. And it really shows us that we should not necessarily think that bonding everything together is giving us the best solution. The approach to preserving tooth tissue many times involves reducing tooth tissue, or to be able to cover some cusps. As you can see, the final fracture here was created by just pushing this wall to the buccal. And the fracture was complete. The only thing that prevented final fracture was a small connection on the enamel side. But from the inside, and unluckily I don't have pictures of that, but from the inside you could see a white line really showing that the crack was through and through the cusp. This needed to be removed anyhow. So in relation to the prep design, it would be great to have some guidelines, and it's hard to find those guidelines really in one source. So we had to dig and find some guidelines. So first guideline, if your isthmus is wide and you have thin walls, there should be cuspal coverage. As I said and mentioned before, 2 to 2.5 millimeter wall thickness is what we need as a base support for walls that we should or could keep. If we don't have dentinal support under a cusp, so undermined cusps with only enamel or a shell-like enamel, there should be some cuspal coverage. Don't expect that just blocking out the undercut or unsupported enamel, blocking it out, would be a solution to the problem, because probably curing composite inside of a shell only of composite will fracture the composite to a final level. If you see horizontal cracks in undermined bases of cusps, this should be an indication, okay, it's time to take action, cover the cusp. A longitudinal MOD crack, it seems pretty obvious to you now, but it's situations where in clinical practice we always need to think about it, and sometimes we might find an excuse or a reason not to do the cuspal coverage. You know, we are always dragged out of the comfort zone, and we have to take so many decisions in one treatment that it's good to come back to the general guidelines. Although they are basic, they should be, I think, respected. If you have an endodontically treated tooth with an MOD restoration, we absolutely need to cover both cusps. And when we have like endodontically treated teeth with a crack in the pulpal floor, I think all cusps should be covered. It's pretty obvious that there we need maximal support and protection. If there's no other criteria for cuspal coverage, this should surely be, the crack inside of the pulp chamber should surely be a reason to cover the cusps. let's take a look at some images that show the hazards of, in this case, amalgam, MOD restorations. And it's pretty obvious to you and clear to you that the internal line angle, which is pretty sharp, is the initiator of the crack inside, and it will crack the complete lingual and also the complete buccal wall. This is not a very, very wide restoration, but still it creates some cracks. And it's amazing to see the effect of the cracks, and it's amazing how long patients can, let's say, survive and stay healthy and happy without any complaints. But at a certain point, they will come to you, they will complain, and you will be the one responsible for finding a solution and preserving as much tooth tissue as possible, and giving them an opportunity really to win time and take it a step further. And this is a patient like this. He had really some faint complaints. It was not very clear. There was some pain, but he could not tell really what was happening. Nothing specific. We really had to dig and ask him a lot of questions to get to know what the problem is or was. And simply removing the old amalgam restoration showed us a very deep crack, a very deep fracture, where you see that even the particles, the aluminum oxide particles that I used to clean the cavity, stayed in the crack. This needs cuspal coverage, that's for sure. And this crack also needs to be, I think it should be chased in a way. I think we should remove or clean out the crack, remove the cusp, and at the same time follow the crack line to the outer contour of the cavity, because if we don't do that, there will be, and we want to keep the tooth vital, of course, there will be some issues. Imagine that you keep the cusp and you keep the height of this cusp present. And even doing a cuspal coverage with a crack open like this, you can imagine that the biomechanical flexure functioning will create some pulpal irritation. This is a living tissue, this is dentine with such a big crack. There's no way ever we could seal off a crack completely from the inside. So the crack needs to be, let's say, cleaned out, removed. We have to have a clear view of what is happening, and especially we need to be sure that the outer contour finally will be sealed. There, we should leave no chance of infiltration of bacteria from the outside to the inside. Another example of the damage and difficulties we face, and it shows us, it brings us close, it brings us slowly to the need for a good approach, but also the need for good materials that can help us prevent those cracks. Of course, we have decay, but we have cracks, and as you can see, the cracks here are not complete yet, but this is really screaming for a cuspal coverage. Preparation and final cuspal coverage. I think another example, and it's pretty clear that we face quite some challenges. We face challenges in preventing those from originating, and we need to stop the propagation of those cracks. So this brings us, of course, to, okay, what materials should we use? What should be the approach? What should be the view on things? So there's some criteria. We want a material that is adhesively connected to the tooth we want to restore. We need some bonding. I told you bonding, yes, indeed, it's not a guarantee that everything will work, but we need something which is adhesive and not mechanically retained like amalgam. That's pretty clear, and we know this for years already. We need preferably a structure or a material that is acting the way the tooth is acting. The mechanical properties should be similar, of course. It makes sense to find a material that behaves the same way as tooth substance. Preferably something with, of course, low polymerization stress, and then something, as you could see already in the clinical images, we need something with high load-bearing capacity. We need something that resists fatigue, and not something that resists fatigue, let's say, limited to the material that we're using, but we want to increase the load-bearing capacity of the total complex of the tooth with its restoration. Inevitably, it leads us to introducing the material that we're focusing on today, and this is the Ever X posterior, a fiber reinforced composite material that, in my opinion, can answer a lot of the questions and can give a solution to a lot of the problems that we touched in the beginning of the presentation. To give you a short, clear overview of the material, it consists of a resin matrix. Of course, it's a composite, so 23%. It's an interpenetrating polymer network. And then we have some fillers. It's some e-glass fillers and also some glass fillers, which can make up 77% of the material. And then we have the third big part. It's the initiators and inhibitors. Now the key, really, the real key, what is important in a material like this, you know, it's in this complex, in the way the matrix and glass fibers interact together. It's not like a regular matrix with just fibers inside. You really need a good bond and integration of the fibers into the matrix, because they need to be able, the fibers, to take over the stress that is created or inside of the matrix. So stress and forces will be flowing from matrix into fibers, and there the fibers will start to act. So the transfer, as I said, from the matrix to the fibers is the key. And there, the fibers, they can stop the crack propagation. Remember, stopping crack propagation was one of the objectives, and not only within the material that we're using, but also within the complete tooth restoration complex. So there again, it's dual. This image, it's wonderful because it shows you how the crack inside of the material will be first deviated along a fiber. It will change direction, and then eventually it will be stopped by a fiber. So this mechanism is really working on a very microscopic scale, and it helps you really to create a material which has some amazing load-bearing capacities and amazing capacities of really resisting high forces. And it's clear to everybody that the forces in the mouth are pretty high, and those teeth, they have to work hard. So this mechanism is the key to all the advantages that we are going to touch and see. So, as I said, load-bearing capacity is high, and it's on a very delicate level, as you know, because it will allow us to create a restoration, to create even a tooth restoration complex which is able to withstand forces. Let's have a look at, okay, what is the maximum bite force? For humans, it's around 1,000 Newton. If you have a conventional composite, we are similar in resistance. The thing is that if you compare a combination of Ever X posterior, which is a base material, I forgot to tell you, but it's a base material that should be covered with another material. It's a dentin replacement material, honestly. that should be covered with another material. So if you look at a combination of every X posterior with an overlaying composite, like the total bare loading capacity is much higher than what you can get with composite alone. Now, this is like the static point of view. When you add dynamic loading to that and fatigue of materials, you see that we will drop 30%, meaning that we get in a very dangerous zone 750, which is pretty much below the original 1000 that the human biting force can represent. With the combination every X posterior and a top layer of like regular composite, we still stay well over the 1000 Newton limit, meaning that the complete complex has a big resistance to that biting force and to the loading. Something which adds to the tooth-saving potential of this material, it's the way, if failure occurs, is the way how the failure happens. Sometimes we find a solution and we find a very strong material. And by putting a strong material into a tooth, we think that we can save the tooth, but the thing we really do is we make the tooth the weaker part, meaning that if failure occurs, it's the tooth that is lost. With this material, especially in endodontically treated teeth, with a very strong core like this, we will be able to create, if there's failure, a failure mode which is less dramatic. We will deviate the crack along the material inside of the tooth, and we will end up with generally fractures which are more above gum level in relation to the situation where you would allow a through and through fracture through composite going deeper into the tooth. So this will lead to catastrophic failure. This will lead to failure, okay, but still it will lead to a failure that will still allow restoration because the fracture line is in an area that is still visible. We can reach it. So it's another advantage. Now, when we look at the other physical properties like fracture toughness. Fracture toughness is another physical property which is for every X posterior twice as high as, or is double than the one of the conventional composite. Pretty obvious. Flexural modulus is closer to the one of natural dentin. So remember I told that, I forgot to tell it in the beginning, but you should see every X posterior as a real dentin replacement. And compared to the behavior of natural dentin, we are getting very close, much closer than with conventional composite. And when you go back to the beginning of the presentation, you remember that I told that we would be looking for materials that really come close to the behavior of natural teeth. If they would act similar, they can work better together. If you have two materials, or a tissue and a material that have complete opposite behavior, they will not work very well. It's very hard to imagine a team of two players that don't work together. So it's the same here. Sometimes in the interaction between humans, you can have like something which is very complementary. But here we need something which is more than complementary. We need to be looking in the same direction. So the material and the tooth and the tissue that we are restoring should have the same behavior, the same intention of working together. Something very, very important. I think this is critical, especially in relation to how the use of the material and the handling of the material and the build-up procedure of the material will still allow a good functioning complex. It's the way how the material shrinks. And let's be honest, the volumetric change of the material after and during and after setting is pretty similar to regular composite, volumetric, and the shrinkage stress. But a very big change or difference is the presence of the fibers. So imagine a material that has a lot of fibers inside, and by placing the material in the cavity and by pushing it down, you are able to align the fibers more into a longitudinal direction, which will allow you to end up with less linear shrinkage. You will have, of course, to compensate and end up with the same volumetric change. You will have a more shrinkage, let's say, in the vertical way, so the complete thing might shrink down, but you will not create the same stress related or in relation to a regular composite on the walls. The linear shrinkage and stress on the walls is less higher. And this is something that will create a more predictable outcome and a less damaging effect. Now, let's look at the real potential of a material. You can think of use of a material in a direct or in an indirect way. Let's see that, or let's imagine that we put some X posterior as dentin replacement. We layer it with a cover, with a top of a regular composite. The thing is that we will increase the total load-bearing capacity by having the fiber reinforced material underneath. Okay? Imagine having one restoration that has as a base, as a framework, a fiber reinforced composite, and on top of that, connected to that, already bonded to that regular or a lab composite, we have the same increase of load-bearing capacity. So it makes sense, both in the direct and the indirect approach of things, to have a support from fiber reinforced composite underneath. Let me focus on the direct restorations. It's something we do a lot. Every day there's patients that really, let's say, need restoration of teeth in a direct way. Although we know that maybe we should go into some indirect restorations, it's good to offer some opportunities for the patient to find a way to win time, to make it financially possible to save the tooth, and maybe to stepwise get to preservation of that tooth. I think it's great to have some kind of protocol, some kind of guidelines of how to address it. So this is the protocol we will go through. We will go through it, of course, with the clinical images, but I think there are some key points, especially when doing direct, that need to be taken into account. There's marking of occlusion and articulation. We need to look before we start. If we start restoring teeth without looking at how they will have to function eventually, anatomically and functionally, it's hard to be predictable, especially in morphology and into shape. So, mark occlusion and articulation. Isolate the field. Before you put any drill in the tooth, I would recommend you to isolate the tooth. It creates a very great view on things. It will be much easier to see what you're doing. It's very obvious. Remove the old restoration and decay. Do some cavity preparation. Do a good bonding procedure. Use the correct matrix systems. Close contacts first. If you have a box, an open box, close the box first. Make sure that then you do the central core buildup, internal buildup, and then do the occlusal obturation and finishing. But let's go into the clinical part. Initial situation where we see that there's some need for a restoration, okay? It's pretty clear there's some decay here, there's some infiltration, probably some primary decay that was left under the existing filling. So if we isolate the tooth, I would say isolate the whole quadrant. It's much easier. Use heavy gauge rubber. You might think, oh, it will not pass difficult and strong contact points, but it will go through and it will create you, and it will give you much more tissue retraction. Do the full quadrant isolation. Put an anchor clamp, preferably distal on the tooth, or distal on the tooth distal from the one you're treating, even 2 teeth more to the distal. Use some floss ligatures, at least for the tooth you're treating and the one next to it, to create more tissue retraction in the proximal. And sometimes you might need to add some Teflon tape or retraction cord for very, very deep isolations and some more tissue retraction. The thing is, you have to create the optimal situation, circumstances to do the work you need to do. It's already very difficult to do dentistry in an environment which is all wet and full of saliva, maybe blood, so let's make it easier, okay? So this is what you see, marking of occlusion. You see the rubber is in place, you have an anchor clamp on the tooth distal, you have some floss ligatures. This is the way how we start out. We remove the restoration, and we find the decay underneath, so we will be cleaning the decay. And of course, we will find some fractures. There were some indication of fractures. Luckily, they are not too deep, they are not too wide. They don't go through and through. So the thickness of the remaining walls is still pretty okay. There is some undermining, but still at the base of the cusp and at mid-height, we still have some dentine mass. So in this case, I would rather, let's say, block out the undercuts and do a good buildup of the restoration. So before we will be using the restorative material, we will need to do a bonding procedure. We need to have an adhesive procedure, and there, of course, some general tips in relation to etching and rinsing. Of course, control the timing. First etch the enamel and then the dentine. Be sure not to over etch the dentine. And avoid, of course, desiccating the dentine after etching, especially with the one-step etch and rinse dentin bonding agents. It's very critical to be sure that you're not desiccating dentine. You need to have a substrate that is ready to absorb all those bonding agents. If you use a self-etch system, one good thing to do could be using carbide burrs for dentin to avoid a thicker formation of smear layer. And then, of course, use a selective enamel etching approach, meaning that you can use the best of both worlds, meaning classical etching on the enamel, which is a totally different substrate than the dentine. So try to really go for the best and the most performant approach for both tissues, because they are pretty different. Not only from tissue, but also from a mechanical point of view. So we're bonding to two different substrates. So try to be as predictable as possible on those two. So this is how it looks like after the bonding procedure. What I did here actually was put a very, very thin layer of flowable composite, just to be sure that my hybrid layer that I was forming during the adhesive procedure is, like, let's say, protected, and it's just a way to be sure that we place the critical margin between restorative material and the recently freshly formed hybrid layer is a little farther from each other. It's not necessarily, you could immediately bond your restorative material to the freshly bonded dentine, But it creates a security that you have a good adaptation of the material to the base. Now, in relation to contact points, I really want to stress that the separation ring is key for contact point, and that the wedge or Teflon tape should be key for the proximal cervical matrix adaptation. Many times people use the wedge as a means of separating the teeth, but the potential of the wedge is overestimated. The pressure of the wedge will drop during the procedure. And you will see in the clinical image how the separation ring is really being the one that separates the tooth. Some type of wedge in the proximal area, in the cervical area, should be pushing the matrix against the tooth. It's more easy and more predictable if you can give the specific function to one of the two instruments. So the wedge for the proximal adaptation, the ring to separate the teeth. If you expect one instrument to do both adaptation of the matrix and separation of the teeth, you will end up in clinical situations where it's not possible. Clinical situations where a wedge is even impossible to place because the cavity is so deep. So the matrix is in place. It should be burnished against the neighbor tooth. We have prepared the cavity. The first thing that we should do now, of course, is close the box to be sure that we will end up with the ever exposterior dentin replacement material on the inside, and it should not be touching the outside world. What I like to use in these cases is a fine brush that will help me sculpt the proximal areas, and it will help me to create a very rounded marginal ridge. In relation to a spatula or a composite instrument, this allows me to create something which is rounded, which is creating a smooth transition between tooth substance and composite, especially the area along the matrix here, and the transition from composite matrix to here. This area is something that is really allowing us to create something anatomically shaped already now without too much need for corrections. So once this area is closed, you can do the buildup of the central part. What I would suggest you, once the box is closed, remove the separation ring and remove the matrix, because it creates a field which is much more accessible. You will have less interference, you will have a much easier way of creating the occlusal morphology when nothing else is hindering you at that point or in that time. Now, in relation to the ever exposterior material, as I said before, it should be completely enclosed by the other material. First close the proximal, then do the occlusal. Use a ball plugger or a micro brush to adapt the material to the floor. It's a material that has fibers inside, so it's not a flowable material. So you will need to give it some time, and you will have to manipulate it to be able to adapt well to the floor. So here you see the injection from the unitip into the cavity, and after adapting it with a ball plugger and giving the opportunity to put the fibers in a more general longitudinal direction, you can do the light curing. In relation to thickness, you could light cure up to 4 millimeter thickness. It's not really what we would advise you to do necessarily. It's not like a bulk fill material. Don't expect miracles there. The material properties allow you to cure it to that depth, but I think if you want to create some longitudinal direction of fibers, it makes more sense to do it in layers of 2 millimeters instead of 4 millimeters. Okay? It gives you much more control of what you're doing, especially in relation to the space that you need to keep for the occlusal part. It makes sense to use 2 millimeter thickness. Now, for finalizing, there are some tips also, of course. When we do the final layer on top, use some air block during the final light curing to end up with a good surface that allows you good finishing, so no oxygen inhibited layer anymore. Respect, of course, the manufacturer's guidelines in relation to finishing points and finishing rubbers and tips, whatever. Avoid heating, because if you heat, you will change, of course, and you will influence the properties of the material adversely. And then finally, for final polish and luster, the goat hair brush with diamond paste still is like the standard that gives you the final glossy result of the surface, or surface polishing. So this is after finishing up the occlusal with some G-aenial posterior. This is the one immediately after removing the rubber dam and occlusal check, and final polishing after occlusal check. And this is the one at recall. Another case which is, let's say, challenging. It's a purely occlusal, initial occlusal approach, but it will show you how the cavity design might change, because here we will do a cuspal coverage, and it's exactly the fracture that you can see in this area. So initial situation, we have the same protocol. Initial situation, rubber dam in place, we remove the old restoration, we clean out the cavity, we clean the decay. You see the fracture line here, which is pretty deep, which is pretty wide. So I needed to chase it down to this area to be sure that I was able to seal it off. I need to be sure that I have a margin that can be sealed off. I should not allow any infiltration there. So I should absolutely chase it down until the area where I see no infiltration anymore. So here you can see it in detail. So once again, the aluminum oxide particles are stuck within the fracture line. So this is reason enough, as you see that it is deep like this, to do cuspal coverage, of course, especially if it's located more closely or more to the side of the wall. Cleaning out, etching, bonding procedure, and then adding the material, and this will really show you the difference between the material which is, let's say, adapted to the floor and pushed against with a ball plugger or a microbrush in this case, and the fibers. So what you saw before was the first layer, this is the second layer. This material is just injected, and here you can see the fibers sticking out. Pushing on top, adapting it to the cavity floor will smooth the whole thing down. Fibers will be more longitudinal, and we will have a very nice surface to continue the build-up with. Finalizing the occlusal part and cuspal coverage, in this case again with G-aenial posterior. First big part was direct restorations. When we go to the indirect part, you will see some similar approach. And it's good because there's not too much difference in handling the material itself as a preparation for the indirect restorations. We will do some isolation, of course, removal of old restorations. There's some initial preparation. We will do bonding procedure with immediate dentin sealing, the build-up, preparation, impression, final bonding. So let's get a little deeper into the tips that we can give you here. We want immediate dentin sealing because it improves the final bonding durability on the indirect restorations. It's known for ages, once again. In fact, what is it? It's like a normal bonding procedure followed by a partial buildup. Then undermined areas should be built up so that you can avoid over-preparation. You will have to fit in, of course, a restoration that is made out of the mouth. It needs to fit into the cavity, so don't over-prep, don't necessarily remove the supported or the, let's say, the remaining tooth tissue that is strong enough. Undermined areas should be built up and removed, and undercuts should be removed. Sharp internal angles anyhow should be avoided in relation to insertion, but also in relation to the final behavior of the restoration, indirect restoration that we will put into the tooth. So what we're doing eventually is create a core of fiber reinforced material to improve the mechanical properties. When you go back to the start of the story, we were able to demonstrate or show the improvement of the load-bearing capacity with direct, but also with indirect. So in this case, the core of the tooth will be ever ex posterior, and the indirect restoration will be, let's say, the final covering layer. Of course, if needed, some margin elevation could be done. So let's go immediately to a clinical example to demonstrate this. This is a very interesting case because it's a very big restoration, and it's clear to us that, and it's endodontically treated, it's clear to us that this needs an indirect restoration. But you can also see that there's an overall need for intervention, because there's cracks everywhere. There's cracks even on those small or around those small amalgam restorations. I think I should especially thank my good friend Javier Tapia for these wonderful cases in the indirect segment of the presentation. And as you will see, he will address the issue according to the rules that you have to play to end up a winner and to have a happy patient. Because look at the mutilation, look at the damage. This is like a severe challenge. It would be a very difficult challenge to do this in a direct way. So it makes sense to approach it with the indirect restoration. So these ones will be restored directly, this one indirectly. You see, same protocol. We have isolation, everything is removed. And then we have placement of the matrix. And here I can, this is the best example of how the wedge was not used as a means of adaptation of the matrix. So here the ring, the old rings with the flat little feet were used to adapt the matrix to the teeth. So no need to make any contact point. So be creative. Use the ring to adapt it to the base of the cavity. You need something that is completely sealed off. And since we will be doing some margin elevation here, remember, it should not be done with ever ex posterior. Use another material, for example, universal flow, G-aenial universal flow, to do the margin elevation. It will give you a good control, a good ability also to put the material in this critical area, and you will end up with a very smooth material, which is highly polishable and retains the polish, especially in this deep cervical area. You see the adaptation of the matrix, especially if you do margin elevation. You need to be sure, completely sure, that this is perfect as adaptation. Okay, otherwise it makes no sense to do margin elevation. As you can see clearly, the material here that was used for margin elevation was put first. It's an other material, so this is G-aenial universal flow. This is ever ex posterior. So first we do this, then we do that. After building it up, you can see that, of course, there's some oxygen inhibition layer on top of the composite, even on the enamel margins. We will need, of course, to re-prep the tooth. We will need to refine the margins. We will have to have, before impression, clear, clean, crisp, clean enamel margins. We need to get rid of the oxygen inhibition layer, of course, otherwise we might have some interaction with the impression material, especially polyethers. So let's look at the tips that Javi could give us in relation to address this. Clean the surface with a brush and prophy paste, for example, if you want to do it old school, if you want to be more quick maybe, more effective and efficient, you could use some air prophy powder to clean and remove oxygen inhibition layer. Remnants of bonding agents or uncured resin, they can interact with the impression material, as I said. And for the final impression, double mix or double impression technique is recommended really for high detail. It's much easier and more predictable to do for very fine, precise margins than with a unibody impression material. So this is the refined preparation. As you can see, very sharp margin, very cleanly designed, clean margin here, clean margin there, everywhere. It needs to be clean, crisp, and ready for impression. No oxygen inhibition layer left. Impression. And then, for final bonding, use aluminum oxide, 27 micron, and a bonding agent to prepare the tooth surface. So you are bonding to composite and to enamel. Now there's something I need to point out still because I was forgetting something very important. So let me get back to one of the slides. Let me get back to this slide. As you can see, this is not ever ex posterior. Be careful. This should be covered, the ever ex posterior should be covered by a very thin as possible layer of, in this case, G-aenial universal flow. Remember I told it should be covered with another material. I forgot to mention it, but here you can see it's covered with G-aenial universal flow, okay? So this is giving us a situation where we will be bonding to enamel and to composite. If we bond to enamel and composite, the only thing we need to bond to is like a bonding agent. So this preferably could be like a classical hydrophobic bonding agent. You don't need more than that to bond to composite and to bond to enamel. The resin restoration that you would make indirectly, of course, needs to be prepared also. There you can use the 27 micron aluminum oxide also with a composite primer for the resin. If you're using, of course, ceramics as a restoration, as indirect restoration, it needs a different approach. It needs hydrofluoric acid etching and some silane to be able to bond. And then as a bonding cement or bonding composite, you could go for dual cure resin cement or heated regular light cured composite for final bonding, depending on the thickness of the restoration, depending on the depth. I would tend to go more to restoration-wise, indirect restoration-wise, I would rather go to uniform thickness in the restoration to prevent some stresses in the material. If you have a very big change in going from very thin ceramic to very thick ceramic in the restoration, there will be a high risk of stress and fractures. So if you could make, like, let's say, a uniform 2 millimeter thickness final restoration, you have the advantage of having done the core buildup with every X, so you have the reinforcement coming from the core, and then you have the top layer in the other material, creating, as we showed in the beginning, a complete complex that has a very good and very high load-bearing capacity. the advantage of having 2 millimeter thickness, evenly distributed thickness final restorations in the indirect is that you can have plenty of time to see to the restoration, to remove excess of composite and reduce the finishing procedure after bonding the final restoration into place. So this is an example of the indirect restoration made out of composite. It's G-aenial posterior, and you see it immediately bonded, integrated, and also integrated with the direct beautiful restorations in the premolars. When we go and when we want to take it a step further and maybe offer some options for patients, maybe compromised situations, and we want to preserve as much tooth tissue as possible. Here it was a perio patient, and we want to combine maximum tooth preservation with some predictability and not too high costs. Well, this could be the wonderful solution of doing it indirect, of course, and using the inlay parts as support for the pontic in between. So as preparation, there was a wax-up. The wax-up is used, well, let's say as a study, but at the same time it will serve as a model for the silicone index that will be used to recreate occlusal anatomy during the final shaping of the occlusal morphology of this indirect restoration. We will have the Everstick fibers as base connected from one to the other side. This is G-aenial universal flow. We will have a good strong core of Everx posterior, and then on top of that goes the final layer of G-aenial universal, posterior, excuse me. So the G-aenial posterior. Honestly, for me, it's like the best of both worlds, especially in compromised patients, and you can be very, you can really be as less invasive as possible in this case. You will see how it will behave and how it will end up in the mouth. As preparation, of course, which is very important, the pontic should be kept as smooth as possible, as you can see, and the wings, of course, should be prepared according to the rules, meaning aluminum oxide, sandblasting, and priming with composite primer. And then following the same rules as the single unit onlay, this should be bonded and of course dried in. This is the try-in, so we don't have optical integration yet. This is the try-in, and then it should be bonded and cemented into the preparation. So this is really offering a very elegant option for the patient, and it really extends the possibilities and creates, I think, a much more predictable outcome, because the problem many times with those restorations that were, let's say, inlay supported was fracture through and through the pontic, so through the composite. If it's fiber reinforced with Everstick, and then if you have a good core in Everx posterior, there is hardly any chance that you will be able to fracture this easily. And then, of course, because the fiber is going into the inlay part, you have a secure reinforcement of the connector part also. I think we look to a very high longevity for this type of restorations. And as I said, we stretch the envelope and we create new possibilities. So I think as a conclusion, I can say that with the potential of a material that can increase load-bearing capacity and reinforce, not only as a material, but can also reinforce the tooth restoration complex, there's some interesting times ahead of us. With this, we come to the end of the presentation. I would like to thank you for your kind attention, and of course I would like to thank all the people for logging in at home. And of course now is the time for question and answer, so stay tuned.